Our next presentation is on the future of diabetes management. This will be presented by Dr. Rajnish Kumar, an internal medicine consultant and diabetologist at Total Health. Dr. Kumar received his medical degrees in internal medicine and anesthesiology, critical care, and started practicing medicine in January 2005. He's an expert in dealing with complicated diabetes cases and has an advantage of the latest technologies by integrating them into the fields of diabetology and preventive medicine. Let's welcome Dr. Kumar.
Thanks a lot to the organizers and Total Health to give me an opportunity to speak about future in diabetes management. Green one. Okay. So, as you know, nobody can predict the future, but I'm going to predict it today. Okay? Because I am more interested in diabetology, so I'm going to predict about that only. I can't predict what will happen, but I can tell how we can manage diabetes in coming future. So the agenda for my presentation today, since it's a very big topic, so I have tried to point it with presentation. So I have divided this thing into roughly 10 points. This will cover our introduction, discovering the role of new genes, breakthrough in alternative therapies, technology innovation in diabetes management, newer diagnostic tools for diabetes, bionic advancement, which is probably will be the new topic for people who are sitting here, and promising research in last few years, including the databases analysis. And finally, how artificial intelligence. You know, since morning, so many presentations have been regarding the artificial intelligence in different fields. So I'm also not going to lag behind. I will also discuss about the artificial intelligence in my field of diabetology. Green one, sir? Top one. Okay. So this figure which I'm going to give you, you know that figure for diabetes assessment and the number of diabetes patients varies according to place where the studies has been done. I have took this figure from World Health Organization, in fact. According to the WHO, the last figure for diabetes mentioned is 422 million people who are affected confirmed diabetes patients. This includes both type 1 and type 2 diabetes patients. This is the exact figure which they have given us. Followed by that, another figure which they have given us is around 98 million adults who are pre-diabetic. This is really a scary figure because pre-diabetes means the people who hasn't been diagnosed to have diabetes yet, they are not on any medication. Most of them even don't know that they are pre-diabetic, but they are going to sooner or later become diabetic. That means this 98 million figure is going to be added on in that 422 million figure, plus new pre-diabetic is going to come in future. Separate from all of this, the rare autoimmune disorder. Some people know about this. Who don't know, I'm going to tell you that there's another type of diabetes called 1.5 diabetes. What is this? These are a group of people who haven't been diagnosed either type 1 or type 2 diabetic. In the early stage, they are insulin independent, but later on, because of autoimmune disorder, they ultimately change or depend on insulin dependency. That's why this is called as 1.5 diabetes. This is not type 1, not type 2. The most common example of this is LADA. Several advancement and innovations in diabetes treatment and management become available over the last few years, including new medication, which I'm going to discuss in detail in my few slides later on. Given the broad impact this disease has on the world's population, it is no surprise that innovation in how it treated have been in the news throughout the years. Now it's an era of Google, so most of the people take the information from there. But this is not mandatory that it's going to be correct. So I'm going to put some evidence-based data in that to prove my points. Now, regarding gene therapy, as we all of us are science graduates, so we know that gene therapy is a type of modality of treatment in which we try to correct the incorrect sequence of gene or replace the incorrect sequence of gene from a corrected sequence genetically engineered by different means. There are two basic forms, two different ways in which we can do it. One is viral vector based and another is non-viral transactions. Transcription is the process in which we change that gene, which has been taught to us in our school days. These techniques are mostly evident for correction of type 1 diabetic because most of the cases of type 1 diabetic are basically gene oriented. Now in this, the most common type of cell mediate which is involved is T cell mediated pathways. But again, this is under research. It's not 100% proven yet. But in future, probably we will get success to find out different ways to do it. In type 2 diabetes mellitus, I will mention two different kinds of genes. One is RNAi gene and one is CRIPSR CS-Cas9 gene. Both of them are under research, but still they are they are showing promising results for correction of type 2 diabetes or at least slowing down of type 2 diabetes enhancement in future. Now, these two things which I'm going to mention right now, they are recently in our newspaper and medias. One of them is the therapy that targets hepatic S100A9 TLR4 mTORC1 axis in a non-parenchymal cell of which suppresses ketogenesis. As we know that the most dreaded complication, or we can say that the complication with which we are afraid of is ketogenesis, because there's a condition called diabetic ketoacidosis, which has almost maximum, you can say, death rate, or because of type 2 uncontrolled diabetes mellitus, type 1, sorry. So in this, what we do, we try to follow that axis to suppress it so that the progression towards ketogenesis slow down and later on leading to less complication or avoidance of ketogenesis. The another mechanism or the second therapy on which we are working on, which has been already approved by FDA, is teplizumab. So this teplizumab is nothing but it's a humanized monoclonal antibody that delay the onset of type 1 diabetes. This targets, again, the T cell only that binds with the C3 receptor. Although the exact mechanism of the action is not fully understood, but it has partially or fully activated signaling system which deactivates, leading to slowdown of the progression of type 1 diabetes for complications. Now, according to my agenda, point number 2, that is technological innovation in diabetes management, I have divided into, you can see in the picture, 4 boxes. One is insulin delivery, second is glucose sensing, third is data management, and last is glucose responsive insulin delivery. Now, insulin, the crux of the story is for diabetes management, we have to correct insulin levels, either from outside or from inside. So insulin delivery, we can, if suppose our patient is deficient in insulin, we are going to give the insulin from outside. So these are the ways in which we can give. First is conventional way, that is the insulin pens. Second, the more advanced version is insulin pumps. Now, insulin pumps again can be used in 2 ways. One is conventional pump and second is patch pump. I will tell you the difference in my later slides, what is the basic difference between the two. Second is glucose sensing, very important point. In any medical management, the most important point is diagnosis. If we don't diagnose it correctly, we can't manage it, we can't monitor it. It's rule of thumb. So here in glucose sensing, basically we can choose for capillary blood glucose, which is the real blood, or we can use CGM, that is continuous glucose monitoring, which can be used in a way that we don't directly check the capillary blood, but we check the interstitial fluid, which has direct connection with the capillary blood. I will discuss this thing in detail in further slides. Third is data management, very important. Data management is important because we need, being a human mind, human brain, we can't have all the data managed in the single brain. So what we do, we try to note it down in some file. And since we have thousands of patients, so it's not possible to put every data on files. That's why we have different ways or algorithm in which we can put this data management so that we can compile it later for research purposes and proper monitoring of the patient. Lastly, glucose responsive insulin delivery, threshold voice sensation. So in this thing, the issue is that if we sense how much glucose is the level of the patient, how we can give and how much insulin should be released. It's very difficult for a person to calculate all the time. He's busy, so it's difficult for him. So now we are developing different algorithms, something like artificial pancreas, which happens naturally in our body, that calculates on itself to release the insulin, how much amount, when it has to be assessed according to automatically. Now, first part, as I said, CGM, full form is continuous glucose monitoring. This is different. In this picture, you can see on the left side, there is a person who has applied one patch on his arm, which is the ideal place. Otherwise, this patch can be used on any non-hairy part of the body. We prefer the arm because it's comfortable for the patient, so that he can do his normal activity of the body. This patch size is roughly, if you consider Cayman Island, if you have seen the 25-cent coin here, is the size of that. We attach this thing behind the hairless, on the arm, just on the hairless skin, and this is activated. Once it is activated, with or without the console, because there are newer CGM in which there is no need for any console or meter. Directly we can download some app on our smartphone, and we can do with the smartphone also. Second is the conventional glucose monitoring, which everybody knows, that in which we have to prick our fingertips and check it with the glucometer. The problem with this glucometer is that it's painful. Every time you have to prick it, whenever you want to check it, you have to check with pricking your fingers. In that, according to the life of that patch, you can use it. For example, if we use Freestyle Lever Pro, it works for 2 weeks. If you use Dextrocom, it works for 15 days. Now, here is a comparison between self-monitoring, that is a blue one, and the flash monitoring. So in self-monitoring, full form is self-monitoring blood glucose, SMBG, in which we check for capillary blood. We prick every time our finger. The frequency, it depends on whatever you want to, whenever you want to check it. It releases the result immediately. It has parts called meter, lancet with which we prick our finger, and the test strips. MARD. MARD means mean, absolute, relative difference. That means what is the basic difference between the real value of the blood glucose and that the value which is coming in the meter is roughly around 5% with the self-monitoring device, which is more in flash monitoring because, as I told, that it senses the interstitial fluid rather than the blood itself. But we have a rough idea that it has 10% difference. Overall, this CGM is better because it has continuous monitoring, painless, I won't say painless, less pain, easy to manage, and data management is better with CGM. So nowadays, normally, we prefer this CGM technology, in which you can see that white portion on the slide on the right upper side is nothing but the sensor. The black one is that port thing which goes inside the skin. And you can see that blood is flowing in the capillary, red capillary blood. It never reaches there, otherwise it may infect it. So it reaches in the skin, subcutaneous skin, where the fluid is secreted. So that, with that, it assesses the level of sugar, and we can correct according to that. We monitor the patient. Now, there are a few demerits of this also. First is sight. If the person is hairy or he has some skin infection, we can't use it. We have to remove that hair. The place where we are putting this thing, skin should be healthy there. Second, warm-up time needed. Whenever you apply this CGM, you can't use it immediately. It won't give you the correct result immediately. We have to have some warm-up time depending on the company, depending on the sensor used. Third, glucose diffuses from the blood into the institution, so that means it will be behind the real value of glucose, roughly around 10 to 15 minutes. But it interprets the trend, which is advantages over the previous conventional ways of managing glucose. Now, there are many types of CGM in the market, but the 4 most prominent are this. I personally like to use the first 2 because they are comfortable. They are economical with respect to the other one. But Dextrocom is also good. Again, you can see there are a few numbers like LIBOR 14, 2, 3. This second number indicates the generation. So in the previous one, LIBOR 1 and 2, you have to buy that machine with the sensor. But in LIBOR 3, it is like an app. You can download in the phone, so you have to just buy the sensor. There is no need to buy that machine to measure it. And that app is directly connected with your data, which can be stored at cloud, so that your physician can watch your change in the blood glucose even sitting in his clinic. Other three are also like same, but again, they are of different models. Dextrocom is like a little bit longer acting. It works 1 day more than LIBOR Pro, but again, it depends how you're using it. Now here you can see that the 6th generation was for 10 days, but later on when it changes generation 7, etc., they can further increase the number of days. So in the first column, I have mentioned the duration of action in which you can use the same CGM. Second is the difference of the time in which it can assess it. Third, how frequently they check the blood glucose in the body. And last is a simple notes about that. So you can see that LIBOR 14 have no low alerts. So you can see once you improve the generation, you have extra advantage of assessment and glucose monitoring in different devices. Now this has the apps, which is very important. So you can see Dextrocom company normally use the reader through which it attaches is our tide pole or gluco. LIBOR also uses the same, but again it depends on type of software which they are using. So these are the basic three which normally uses different kinds of software for assessment and future collection of the data. In this figure, I have tried to compare the CGM targets in different category of the patients. First category is simple type 1, type 2 diabetic patients. Second category are older and high-risk patients. Third is pregnancy, which is always a high risk, but again, we consider depending on the class of patients. And last is gestational pregnancy, that is gestational diabetes. The green column tells you about the target range. So here we can see there is another concept of TIR. That means in the time period in which maximum sugar of the patient remain in that target. For example, in column 1, we can see the target has given to be around 70 to 180. That means if the patient have maintained 70% of its timing in whole day, in this range, it will be considered as controlled blood sugar. Similar way in the other categories, it has been mentioned. So this is called time in range. With the time in range, we can easily calculate the EA1C. EA1C is different from normal HbA1c. It's a rough estimate of HbA1c because you can't check the HbA1c every time. You have to prick the patient, send it to the sample, waiting time, etc. So by assessment of TIR, we can give a rough idea that, okay, his assessed EA1C could be how much. Depending on the type of patient, pregnancy, neurosurgery patient, etc., we can manage accordingly to that. So here we can see I have highlighted especially the lower three rows here. That is, if you maintain 70% of the TIR, you can manage EA1C by 7%. According to that, 90%, 6. You can imagine that more the time limit in TIR, better is your EA1C. It's 6. Okay, so below 6.5 is always our target. Now, what are the benefits of CGM? It's a very common question which people ask. Why should I spend more money if I can manage my sugar levels with a normal conventional glucometer? So this question, in a very formatted manner, was published in JAMA network. For adults with poorly controlled type 2 diabetes. So remember one thing, CGM is not for a well-controlled, new diagnosed patient who has a good amount of sugar control. CGM is basically required or indicated for people in which intensive monitoring of the blood glucose is required. So for example, if I am a diabetic, my blood sugar is 6.5 HbA1c, I need not to use CGM. I can use once 7 days or once 3 days my glucometer with a normal conventional glucometer. But for people in which it is required as a continuous glucose monitoring, we should use preferred CGM. The question was, which was published, for adults with poorly controlled type 2 diabetes treated with basal insulin without parenteral insulin in primary care practices, does CGM improves HbA1c? Very interesting question. Without changing the medication, can we improve the HbA1c in a patient by using CGM or technology? Yes. The answer is a big yes. So it's not a very big study, but it's in which they took roughly around 175 patients, out of which in 116 they use CGM monitor, and in 59 patients they use normal glucometer. They realized that merely by monitoring with CGM, they can reduce the last points. You can see 0.4% better HbA1c, which is significant p-value with respect to conventional one. That means by giving better monitoring without changing the medication, we can improve the HbA1c by almost 0.4% extra. Now, smart pens. This pen is smart, not in a way that it is smart. It's smart because I'm using it. Remember, smart means anybody who has its brain. Humans are always smart. We always say that human beings is a smart organism. We never say that we never say that turtle is a smart animal. We say dolphin is a smart animal. Why? The people or the organism which can sense, which can organize the data, which can use that data for its benefit, they are called smart. So how they are different from a normal pen? In a normal insulin pen, we decide how much dose, what insulin, everything we decide. In this, what happens, that this pen are organized pen which have via the Wi-Fi connection or via different kind of software, they decide how much insulin has to be given, when to be given. If it can't be given because of some reason, it will give you alarm. So that means they can think. They are not like super thinkers, but they will at least assist you to manage the patient. So people living with type 1 diabetes have numerous advanced technology to choose from, better manage their type 1 diabetes. Continuous glucose monitoring, insulin pumps, artificial pancreas systems, which combine or you can combine the two. We call it artificial pancreas. These technology can make managing type 1 easier and help facilitate better outcomes, fewer experiences of low blood sugars. So remember one thing, in diabetic patient, I'm not afraid of hyperglycemia. I'm more afraid of hypoglycemia because hypoglycemia can make it dead. Hyperglycemia, you have enough time to meet your doctor, you can manage the things, but hypoglycemia, if you don't control it, you don't come to know about that, it may kill you. There is no such thing as too much options to choose from in type 1 diabetes, type 1 management. We know that the treatment is insulin, only longer acting, short acting, whatever. What we can do in advancement, we can change the delivery devices in different ways. Now, people living with type 1 diabetes who prefer multiple daily injections like MDI, here we can utilize this technology for betterment of the patient and better management of diabetes. Now, these are innovative devices used for multiple dose insulin administration. There are different companies. I have opted for two most advanced, which both of them have been approved by FDA recently. And one of them, like Pediatronics, is already in use for last 4 years. So these devices have made that few changes in the pen in such a way that it can assess your value of sugar through your sensor via the Wi-Fi, and according to that, they can deliver the injection. So you don't have to load it. It's already there, loaded, the moment you try to take it. So there are a few already companies in the market, so I have tried to compare different things, but few of them are older ones, few of them are newer ones, so obviously the things which comes later, they have more advantage than the older versions. Like conventional insulin pen, insulin smart pen can be used as a certain long or short acting. So when this smart pen came, it was only used for longer type of insulin, like Lantus, etc. Later on, they organized it in such a way that now it can be used for both shorter and longer acting insulins. Unlike conventional insulin pen and insulin pen caps, in pen, like Bigfoot Unity, do a lot more than physical delivery of the insulin. That means it assesses the data, it controls it, it decides what dose tube has to be given. So that's the reason why we call it a smart pen. More specifically, insulin smart pen or caps can calculate, as I told you, it can calculate the dose. of depending on the whatever he is eating, when he is missing the diet, whenever his blood sugar fluctuating, it can calculate it. It can also calculate the basal dose. It can also calculate the bolus doses. Number of times, it can correct the hyperglycemia easily and also avoid hypoglycemia. Track the time and amount of each dose. So just imagine that a person who is on insulin pen, he's putting 4 injections in a day, 1 long-acting and 3 short-acting. He can't remember all the information like what time he calculated the dose, etc. So he has to write on some piece of paper. In this smart pen, you don't have to write anything. It's going to be calculated, send it to your sensor, from sensor to the Wi-Fi, through the help of Wi-Fi, it goes to your cloud base, so that at the end of the day, you can see how much insulin you have consumed, what is requirement, whatever. So in this way, this technology has helped a lot of physicians to managing the patient in a better way that they can easily calculate without any biasing of the dose. What are insulin pen caps? These are a little bit different. So one most common problem which the people face who are on insulin therapy is the temperature maintenance. It's very difficult to maintain insulin. Suppose in Cayman Island, you're like a on-road guy. You all the time travel on the road, and you have to carry your pen in your pocket. It's difficult to maintain the temperature because that can lead to loss of efficacy of the insulin. So in this insulin pen, what happens, you can see in the picture, there's a cap-like structure, like a pen cap. It has to be attached over the insulin pen, and the moment it senses that temperature is going up or down, it's like a small air conditioning of that insulin, only for that pen, so that it maintains the quality of the insulin. So it's again a newer advancement, though it has no direct contribution towards the management of the patient, but it plays an important role in maintaining the quality of the insulin. Insulin pump, very interesting point. As we know that in human body, there's an organ called pancreas. Pancreas have a lot of different cells. I'm basically going to concentrate on only 2 types of cells. One is beta cell, one is alpha cell. Alpha cell produces glucagon, beta cell produces insulin. Everybody talks about insulin, but nobody talks about the alpha, that is the glucagon. I will tell you in detail. So for the time being, insulin pump has basically 3 parts. One is that sensor that senses the sugar levels. Second is that port, and third is that machine which has the insulin cartridge in it. So if you can see on the right side, there's a guy who has a sensor. Sensor senses the level of sugar, send it to the data there in the machine. Machine calculates the dose, and it releases the insulin. Mostly, not mostly, most of the times it is used only for the short-acting insulin because it acts like a normal pancreas, which is in our body, which releases the continuous release of insulin. So it's a very good thing for people who are especially type 1 diabetic because the same way it behaves like the way it behaves in a normal person. It is called pump because it has continuously, it can release it. Now in this picture, you can see that, so left side, I have mentioned different parts of the artificial pancreas or the insulin pump. On the right side, you can see that this dual hormone, this is a newer thing which has come recently in the market. Things are going on, but it will be sooner available. This is called dual hormone artificial pancreas. Just imagine that in a normal person whose blood sugar goes up. Your body senses, pancreas senses, beta cell senses it, release the insulin. Now imagine that his blood sugar goes down. So when his blood sugar will go down, insulin won't be released. But it don't assure you that his sugar will be okay. So there must be somebody in our normal body, in normal person body, who is saving us from hypoglycemia, and that is glucagon, which I was talking about in last slide. That means between alpha and beta cell, there is some kind of communication which hasn't been proven yet how this happens, but it happens at a cellular level. So in a normal person, if blood glucose goes up, you release, beta cell releases insulin. If it goes down, significantly down, then obviously insulin will be stopped, but at the same time, glucagon will be released to counter-regulate the sugar levels, which was missing in type 1 diabetic patient because in type 1 diabetic patient, there is no beta cell or low beta cell. So that means there is nobody who can tell the alpha cell that, man, I need your help, please help me up to lift the sugar levels. So that principle we have used in this dual hormone artificial. You can see here there are two hormones. One is insulin, one is some kind of counter-regulatory insulin hormone like glucagon or pyrimidine, etc. So that means this is the real or true artificial pancreas. Though the structure is big enough at the moment, but you know that as the medical science improves, sooner or later we will have the reduced and small size of the different pancreas cells. So promising research in last few years. This is a long list of research which is going on because diabetology means money. A lot of people are involved here, a lot of patients are there, so there are a lot of companies who are pushing money in this. So there's a long list in different fields, right from the diagnosing to managing to insulin pumps, etc. There's a lot of researches going on. There's a long list regarding the management. Now, artificial intelligence. Everybody discuss about artificial intelligence, so I'm not going to lag behind. Artificial intelligence we can use in data management, we can use in monitoring, we can use in management and calculation of the patient's dosing for the insulin thing. So this artificial intelligence tells you about level of sugar, when, how, what amount of insulin, which kind of insulin you should utilize for the patient. Plus, also manages the data for the patient. Now, few things regarding the medications. Insulin is fine. Insulin, we have talked a lot, but that is basically regarding either type 1 diabetes or 1.5 diabetes. As we know that most of the type 2 diabetes people, most of the time of their life, they don't need insulin. So medication is also important. So in the field of medications, there are a few research which I'm going to go ahead with this. First is metformin. Metformin is the first line of medication for type 2 diabetes. It also reduces other kind of complexity. So as we know that there is something, here I would like to mention something called legacy effect. Legacy effect is a concept given that if a newly diagnosed diabetes patient, if his sugar get uncontrolled in the first few years of his diagnosing the diabetes, it can damage his body more rather than to control his sugar later on. That's why we pressurize more on pre-diabetes and newly diagnosed diabetes people for their management. And it's a lesson for the community that the moment you come to know that you have diabetes, please, please, please don't ignore it. Because later on, body is not going to give you time for management. Complications are sure. Mostly the macrovascular complications, including the stroke, the cardiac issues, etc. Okay? So the second group of medication which I'm going to mention is SGLT. SGLT is a type of group of medications which also helps you for avoiding kidney complications, etc., along with the sugar control. GLP-1 analog, very important. Nowadays, everybody wants to be thin. Everybody wants to talk about obesity, obesity, obesity. But here I'm not going to push about obesity. I'm going to talk about diabetes with obesity. As we know that itself, obesity is a risk factor for type 2 diabetes. Anybody who is overweight, risk. Only, I'm not talking about smoking in family history. I'm talking about only overweight. Try to be fit. Run on 7 Mile Beach. And if you fall down, come to Total Health. So GLP-1 analog, most commonly what we use nowadays, which is already approved. I myself is using it for last 2 years on the island. Myself means I'm not me, in my patients I'm talking about. So GLP-1 analog, most commonly we use semaglutide. It is available in two broad groups, two names, different companies. They comes in both oral and injectable form. Oral is available in 3 milligram and 40 milligram. Injectable is available, depending on the company, from 0.25 to 1 to 2 milligrams. Up to 1 milligram is recommended for weight loss, but for diabetic control, you can go up to 2 milligram without any issues. After that, GIP/GLP-1 analog. This is mother and father of semaglutide. It came recently, last year, November 2023. Obviously more expensive because it came later on in the market. The most common brand name used is Mounjaro. People must be familiar with the Mounjaro, but they don't know how this acts. Later the medication comes, less is the complications, more expensive it is, and better results. So I will show you a picture later on. Later on I will show you a picture about the comparison between different injectable diabetic medications. Now, about SGLT, in this figure, I have given a comparative figure that they are different salts of the same group, Which is better? It depends on the physician and the patient. Physician decides that what complication risk is there. According to that, we select different kinds of salt, but they all, flozolene belongs to the same category called SGLT2 inhibitors. GLP-1 analog with CV and CKD benefits. Semaglutide current supply chain, as I told you, different strength available. Other things are liraglutide, duglutide, but the best part about semaglutide, it's a weekly dosing. Very good compliance. Once a week, it's a hypodermic needle, painless. But other things are mostly generally daily dosing, so it's cumbersome. Other available brands, salts in this group are exentride and lisinopride. Ask about, okay, there are few indications in which we try to avoid this medication. This is mentioned in this slide, especially thyroid related. If somebody has some history of medullary thyroid cancer or some thyroid issues, be extra cautious. Other than this, any pancreatic or gallbladder disease, be extra cautious. With the use of semaglutide, I have figured out that incidence of gallstone has gone up. The commonest complication which I figured out is in first few days of starting the semaglutide is GI symptoms like nausea, vomiting, constipation is quite common. Now this is the medication which I was talking about. The salt name is tirzepatide, brand name is Monjaro, and right now it's only one brand, so we can mention the name of the brand, not a problem. There's no competitor there. So it has dual effect, that means it has effect of semaglutide, plus it has additional effect of gastric inhibitory polypeptidase. So that further decreases the gastric motility. That's why you feel all the time full. You eat less, obviously you calorie deficit, you lose the weight. And when you eat less, obviously you control your sugar in a better manner. To prove this, there is something called SURPASS-2 trial, as I have just mentioned this, just for the reference. Now in this figure you can see different columns. You can see that we have used tirzepatide at 5 milligram, 10 milligram, 15 milligram, and semaglutide 1 milligram as a comparative study. Maximum weight reduction and sugar control is with the 15 milligram of tirzepatide. And remember, this thing is used alone. We haven't attached any other diabetic medication or oral hypoglycemia along with this. Same thing here for the weight loss. Right now is the best medication available for weight loss by controlling your diet thing. So the formulation available with this medication is 2.5, 5, 7.5, 10, 15, 20, and last, I think 30 milligram is available, which is not available in Cayman. Cayman, we have maximum 15 milligram available. So the whole crux of the story is diabetes can be managed. There is no way why you should feel disheartened that you are diabetic. There is nothing left in the diabetes, especially I'm talking about type 1 diabetic people. But for type 2 diabetes people, prevention is better than cure. Anybody who has overweight or BMI of more than 25 in this hall, please take care of your weight. I'm not scaring you, but it's the reality that everything so remember one thing, overweight, diabetes, and hypertension. They are three very close sisters. If you allow any one of them to enter inside your house, so-called home, that is your body, the other two will come sooner or later. It's rule of thumb, so better be cautious. And if you come to know that you have some kind of issue like this, better to meet your physician to classify the things, assess, and according to that, they can send the patient further if they can't manage it. Here comes the role of preventative healthcare. Especially if you are more than 30 years of age, or you have any family history, etc., better to be cautious to check your bloods at least once in a year. The basic one, the blood sugar, the CMP, the CBC, etc. And if you have some underlying medical problem, please don't ignore it. You should address according to that, as advised by your physicians. Lastly, I have mentioned about hybrid closed loop. It's a fascinating name for artificial pancreas. It's the same thing which I've just mentioned in the last few slides, that it's a combined group of different machines which allows your body to use and control your sugar in a better way. These are the few references which I have took for, just I mentioned for your reference. You can read in detail about this thing. Thank you.
Thank you very much, Dr. Kumar. Do we have any questions for Dr. Kumar based on his presentation? Going once, going twice? If not, thank you very much, Dr. Kumar.
I know there must be some diabetic here, so I will request at least the diabetes people to ask question. At least. And if they are not here, then at least the overweight people.
Okay, so we do have at least one question over there. I think I might also have a question, but let's see.
Yes, sure.
Hi, Dr. Kumar. Thanks very much for the presentation.
Thank you.
You referenced the single use of the semaglutide, but what role is there for the additional anti-diabetics medication? So can you add metformin to the semaglutide, and will that mean you can go for a lower dose to achieve the same effects?
So first of all, the dose of, you are talking about GLP?
Yes.
GLP is a beautiful drug, okay? Because there's no definitive dose for that. GLP is never ever an individual or first medication of choice for sugar control, rule number one. Being a physician, we should not start it to control the sugar directly with the GLP-1 analogs. We should always try, especially I'm talking about type 2 diabetes because we are considering the insulin resistancing, always try with the oral hypoglycemics. If they fail, then only it should be integrated with something which is cheaper, which is easily available, which is less complicated. So I generally consider GLP-1 analog starting from the lower dose because of considering two things. First, the side effects. We don't know how your body is going to respond. In my, roughly I have 900 plus patients on the island who are on this medication. Out of that, 15% has complained me about GI symptoms. So 15% is really significant. That is the reason why I started to use 2.5 first, look at the results, how it responds, then go to 5, then like this, we slowly increase the dose. And it is always integrated along with some oral hypoglycemics. It should not be used as a first-line drug for type 2 diabetes. One more thing. Now you have asked about this thing, which I have skipped in a slide. It should be avoided in type 1 diabetics. Reason, whenever it is integrated with insulin, it may lead to drastically low blood sugar levels. It's always a threat. I'm not saying that you can't use it, but the studies don't support to use it. You can use it according to experience and whatever. You can start with a lower dose along with that, but you have to be more vigilant with that. So answer to your question is, I would like to start with a lower dose. There is no calculated dose like metformin 5 and twice a day, something like that, because otherwise also it's a weekly dosing. So you know that T-half is roughly for 5 days, so you can't say that it's the exact dose for this much kilogram. There's no per kilogram something. So we start with 2.5 or the lower, 0.25, then go with 0.5 like slowly. So we shouldn't jump on the higher doses.
Thank you.
We do have a question at the back.
That's a very interesting presentation, Doc.
Thank you, Anne.
I fully understand how insulin...
Where are you?
At the back of the room, over here.
Sorry. Sorry. Yes, ma'am.
Yes. I fully understand how insulin pens are used. You inject X amount of units under the skin, but I need more clarification on the insulin smart pens. How are they actually used practically?
Ma'am, first of all, insulin smart pen and pen of insulin is same. What is smart is it's the pen, the device is smart. So in that pen, suppose there are two pens. One pen has additional length in which there is a chip inserted inside that, behind the plunger. So it can assess it, it can coordinate with that data, and then it can load it. But you have to inject. It can't be like it will be injected, you are going to put it like this, injected, it's not happen. You have to inject it. What is the advantage? You don't have to calculate the dose. You don't have to write that data on the piece of paper that this was insulin I took at this moment of time. It's not, that's why in the beginning I said it's not fully smart. The smartness has just started.
Let me throw one your way. Yes. So the past 2 days we've been hearing the results of the STEP survey. So we see the diabetes situation in the Cayman Islands. can't remember the specific stats, but they're quite high. Everybody has a smartphone pretty much.
Yes.
So let's look at the future of diabetes management in the Cayman Islands, specifically with all these advances. How do we take advantage of these technological advances across the wider community to ensure that we are preventing diabetes from spiraling out of control and causing other issues?
Very good question. See, first of all, like any other medicine departments or medical disease, we need data. We must have got something called Central Diabetes Command. I'm not asking you to build up a big building and big force. No, nothing. Because we are going in an era of technology. So we should utilize that technology as much as possible. When we say that Central Diabetic Command, that means it could be a software, it could be a computerized thing somewhere in the health ministry or wherever. So whenever, you don't have to go door to door. Any patient visit to any physician on the island, you have to just give him a performer, sir, what you have diabetes or not, or my lab has detected it or not, or what is the sugar level, how many years you have, the small 10 questionnaire soft, you can do that, upload in the system. At the end of 6 months or 1 year, few people who are qualified people or whatever, appointment by the government, whatever, they can sit, assess, and manage the thing. Once it's there, the problem with Cayman Island is that most of the population, not most, 50% is mobile population. So you can't rely on the information completely. You have to distribute the people who are going to continue here, like the residents and the PR holder and the people who are expats. So you can't rely on the information completely. So here is the role of a human thing, that I have to assess that, oh, he will be Caymanian, he will going to stay here, so he's going to impact our financial load. Because if I'm an expat, tomorrow I got a kidney failure, I'm not going to reside here, I will go back to my country. Why should I stay and give so much of insurance and this and that? So that means that has to be assessed by a human being, that is doctor. So what I did in the past, I did similar kind of studies also in Singapore. So there we did the same thing. We took out all the population. We didn't go on door to door. We distributed one, just the survey you are talking about, same survey we have given to different clinics, especially physician clinics and gynecologists, because these are the two branches who deal with the diabetes most. Surgeons generally don't deal, but gynecologists, don't underestimate them. They deal it. After physicians, they are the most important specialty who deal with diabetes because they look after the gestational diabetes. And gestational diabetes is a thing which in future mostly gets changed into diabetes. So these two are the important things. So we can go in a way that we can appoint few people who can formulate that table of paper, distribute or send them online. Sir, fill it, and every month you have to report, just like a notifiable disease. Notify it, we are going to assess that. According to that, we can formulate our own protocols and we can start it.
Okay, I think we can take at least one more question. Yes. There's a gentleman with his hand up.
Yes.
And
Yes, sir.
We will get set for the final presentation. And
You know everything, sir.
into
Why are you asking? You know everything.
And I'm just, just a couple of comments, and just to respond to the, what steps can we take?
Sir, sir, hold on. Sir is an endocrinologist, so he knows everything. So whatever he is saying,
I don't
before
try to know
that,
everything,
I
but-
accept you.
Yeah. But it's just in the context of technology and diabetes, more than technology, in order to reduce the incidence of type 2 diabetes, I think there has to be more funding towards obesity management. Yes, and that is going to be the first step to actually reduce pre-diabetes and diabetes. So that is just my comment.
Yes, sir.
My question was regarding the figure that you showed about pre-diabetes. The 98 million seems a bit too high to believe, even considering the rise in obesity here. And I just wonder whether we are overdiagnosing impaired fasting glucose, because a majority of these people who have glucose levels between 100 and 105, they are unlikely to actually proceed to type 2 diabetes. And so I don't know whether it is a good thing to be overdiagnosing, because even when we are overdiagnosing, we are not actually reducing the incidence of obesity. So is it a good thing or bad thing? I just want
Sir,
to...
in my opinion, it's my personal opinion. I could be wrong. I'm not counteracting you. I will like to scare my patients to control their sugar. My answer is I will favor that. Even if they give me a figure of 198 million rather than 98, it's my opinion. I may be wrong. So I will like to show you those strong figures, make you scared, and control your sugar thing from tomorrow. So you asked me about my thought. I will say I will go with that. But again, you are right. Again, the thing is, figures they never tell you the truth. Who has assisted, in which population you have assisted. Even in your lab values, what reference value which you use, who knows that it's a correct reference value? Nobody. Yes. Yes, that's what I'm saying. If you say that if you have assessed an American community, how could you compare, you can put that reference range on an African community? It's not possible. Their physics is different, they eat different, they live in different environment. I agree with that. But we have to draw somewhere one line. And since most of the studies are American studies, they put money in that, and we don't have other reference values. We have basically right now 2 different kinds of values. One is coming from UK and one is coming from the US. So we have to figure anyone as a reference, just managing the patient. So number 98 million, more than 98 million is not a problem. The thing is the number is big. Even if it's 48 million, it's a big figure. So we can pick up those pre-diabetes early, especially by looking at his figure, etc. We can ask them to manage.
Thank you.
Thank you. We have a final question at the back, and then I'll ask Dr. Kumar for his final thoughts.
Yes.
I just wanted to say something that I think is very important, right? I think it's good for patients to know that they're pre-diabetic, so that something can be done with it in terms of eating right and exercise. Because I've had pre-diabetes for the last 10 years, and it's because I found out that I was pre-diabetic that I did something about it in changing my diet and including exercise. So I think it's very important for persons to know. So something can be done about it.
Just to add on, ma'am,
And
last
this
point.
is without medication.
Last point for you, just for addition. We should not get scared of the pre-diabetes. Why? Because otherwise also no clinician on this planet treats pre-diabetes. We never treats it. We always say, ma'am, you are pre-diabetic. It could change to diabetic. Please take precaution. Follow exercise, diet, etc. So we should not bother with the number of pre-diabetes, but we should always take consideration of that because they may change into diabetes. So you rightly said, if you maintain your diet and exercise, you could be hold on there. And just to let you know that pre-diabetes is 100% reversible, which is not always true for the diabetes. So better to get scared of pre-diabetes rather than to get with that.
Thank you very much, Dr. Kumar. Let's give it up for Dr. Kumar.
Perfect. Thank you. Thank you, sir.